Good evening, chairpersons, colleagues and seniors. The first abstract that I'll be presenting today is from the Senamac trial. This is the recurrence-free survival data which came out following sentinel node positive breast cancers where patients were randomized to completion axillary lymph node dissection versus not. So, I mean, we all know that Acazox Z11 and Amaros showed comparable survival rates in patients who were not undergoing a completion ALND. But we also know that Acazox Z11 has been one of the most hotly debated and contested trials. There have been multiple issues that were raised with the trials, including excellent survival outcomes, radiation protocol deviations, major statistical fallacies, enrollment not meeting the accrual goals, and of course, inclusion of tumors we all want to treat but don't really get, right? So authors felt that there was an underrepresentation of patients with macrometastasis, patients undergoing mastectomies, tumors that were larger than 5 centimeters, ER negativity, extranodal extension, and lobular carcinomas. So this was a prospective 1:1 randomized controlled trial. It was a non-inferiority trial where both male and female patients with T1 to T3 clinically node negative invasive breast cancers with a mandatory preoperative axillary ultrasound undergoing either a BCS or a mastectomy with up to 2 sentinel lymph node macrometastasis were randomized for either the standard of care, which they called as a completion axillary lymph node dissection, versus intervention where you were not undergoing a dissection. Now, it's really important because all patients with BCS obviously received radiation, and the PMRT guidelines were according to the national guidelines for radiation, which was the Swedish guidelines. Now, the arm of the study did not decide the radiation fields, and no radiation was given to level 1, but patients who received radiation, all of them received radiation to level 2, level 3 axilla, as well as the supraclav fossa. The primary endpoint was overall survival. The secondary endpoint is recurrence-free survival, and that's what they have reported on in this presentation at SABCS. They had a non-inferiority margin of 2.5%, and the target accrual was about 3,000 patients with 190 events that were required for statistical power. Now, I think the main thing was that there was obviously no difference in the recurrence-free survival. They had about 2,540 patients. Their median age was 61. And their median tumor size was 20 millimeters. 85% of the patients had macrometastasis, vis-a-vis if you look at Acazox Z11 or Amaros. Non-sentinel lymph node metastasis on axillary dissection was actually quite high. It was 34%. Almost all patients received some form of adjuvant systemic therapy. Only 27 patients out of 2,540 patients didn't receive anything. Otherwise, everybody almost received either chemotherapy or endocrine therapy. And almost 89% of patients received radiation, right? So both arms, I'm talking about both arms. And obviously, as you can see, I mean, the lines are overlapping. There's really no difference between the recurrence-free survival events. And actually, if you go to look at it, their statistical component was really bang on. They had a very high alpha power. They had put it at 10%. Their power to detect the difference was 80%. The alpha error was 10%. And as you can see, it's not really they've not really drawn the line here, but it's not crossing the non-inferiority margin, which they had set at 1.4. So they concluded that if your patient has 1 to 2 sentinel lymph node macrometastasis, you can safely omit an axillary dissection because it is non-inferior. And because the statistical analysis or the statistical part was so robust, they said it was more or less a done thing. Now, though, while the strengths of the study are those, there are 2 important aspects that we have to remember. They did the study because they wanted to see whether they have a diverse group of patients. Now, except for the fact that, yes, they did have more macrometastasis, they only had 6% of tumors that were more than 5 centimeters. They had the same percentage of patients with ER negativity. They had the same sort of tumor size, more or less the same sort of lobular cancers. So it kind of even though they said they wanted to look at other data sets, they kind of more or less matched whatever was there in terms of patient population when it came to Z11 or Amaros. And what we have to remember is that 89%, 88, 89% of patients received adjuvant therapy, almost radiotherapy, and almost all of them received some form of systemic therapy as well. Their median size was 2 centimeters, their median age at diagnosis was 61, and they had 86% ER positive tumors. They've obviously not reported on the primary endpoint because they've not yet reached that follow-up, so it's a short follow-up as well. So what do we do with this? They say they have different data, but it's technically the same subset of populations. So yes, it can be applied to a very select subset of older patients with small hormone receptor positive tumors. But the million-dollar question is, how many of these do we really see in our clinics? We have younger women, we have larger tumors, we have more hormone receptor negativity, and they had 35% of non-SLN macrometastasis. So how much of it can be really applied is still, I would say, really, really debatable. I'm sure the radiation oncologists will not agree with me. The second study is local recurrence after breast-conserving therapy in patients who had multiple ipsilateral breast cancers. So, well, we all know that BCT is safe. You can do it. It's equivalent to an MRM if you follow it up with radiation. And we also know that better imaging techniques, better systemic therapy, better radiation techniques, better surgeons and great pathologists have all decreased your local recurrence rates, and obviously your overall survival rates have also improved, right? Now, what this was actually was, this was a prospective trial. It was a single-arm trial. It was for women above the age of 40 who had 2 or 3 biopsy-proven foci of breast cancer, out of which 1 foci had to be an invasive foci. They said anything which was up to 5 centimeters with a minimum distance of 2 centimeters between the 2 foci could be included in the study. It had to be limited to 2 quadrants of the breast. They said you need an ultrasound and a mammogram, and they kept the MRI as an optional investigation. They obviously wanted negative margins in the study, and they said that you have to give radiation to all the cavities as an additional boost. And what they wanted to see is whether the local recurrence rate with breast-conserving surgery followed by whole breast radiation and boost at 5 years is 8%, which is what we kind of know for regular BCT. I mean, that's what our data says, that at 5 years, local recurrence across all groups should be around 8%. Now, they had a very small number of patients as expected. They only had 204 patients, out of which 193 completed radiation. Median age was 61. Number of foci, most patients had 2 foci, 96.6% of patients. Number of lumpectomies, so if they could get all the foci out through 1 incision and 1 lumpectomy, and that was about 30%, but if they needed 2 separate incisions and 2 separate lumpectomies, that was about 67%. Initially, the number of patients that they thought was clinically T1 was 60%, but when they actually went back to the pathology report, they realized that the number of patients who were actually T1 on pathology was 77%. 83% of the patients were hormone positive, 80% of them were ductal histology, and 73% of them were grade 1 or grade 2. So what did they say? They said after a follow-up of 66.4 years, their 5-year local recurrence rate was only 3.1%. Cool, right? And they said that the 5-year local recurrence rate for patients who did not receive endocrine therapy was 12.5 versus those who did was about 1.9. They also said that the ones who underwent a pre-op MRI had a lower locoregional recurrence. Now, if you really look at the numbers, the number of patients who had a local recurrence was 6. Nobody had a regional nodal recurrence. Distant recurrence was 4. All these 4 patients did not have a synchronous local recurrence. Contralateral breast cancer was 6, other primaries were 3, and deaths were 8, out of which 1 was breast cancer related. So what they said is, if you're doing BCS with adjuvant radiation and you're able to give radiation to all those sites, you could probably give an acceptable 5-year local recurrence rate, even if the patient has multiple invasive breast cancer foci in the breast. And thereby, it's a very, very reasonable surgical option. but we're dealing with a very small number of patients. We're dealing with a small follow-up. There's an undue emphasis on MRI, and we know that MRI has been shown to increase your false positivity rates. It's expensive. It's associated with an increased rate of conversion to mastectomy. And we also know that 22.6% is erroneous because the denominator is 15. So, statutory warning, please proceed with caution. Older patients, small hormone receptor positive tumors, you need an excellent diagnostic technique, you need an excellent radiation facility, and even then, how many of these women will really end up for a breast conserving surgery? So maybe we should do our own trial with this. So, thank you.